Welcome to the meeting of the Health and Wellbeing Board being held today on Thursday the 10th of February 2022. This is our first meeting of the year, so I'll say Happy New Year to everyone, although it seems a long time ago. Point one, apologies for absence. Do we have any apologies for absence?
Yes, Chair. Apologies from Neil Bradley, Kath McAvoy-Carr, Rick O'Farrell, Councillor Simpson, Pam Travers and Councillor Jeff Watson.
Thank you very much. Point two, minutes of the meeting held on Thursday 9th of December 2021. Can we confirm them as a true record? Agreed. Right, great. Thank you very much. I shall sign them at the end of the meeting. Point three, disclosures of interest. Does anyone have an interest to declare? I'm looking at councillors here. Nope. Okay. So I go to point four on the agenda, update on the epidemiology of COVID-19, Northumberland COVID-19 Outbreak Prevention and Control Plan. I think it'll be Liz Morgan.
Yes, thank you very much. And I think Rachel's also here to talk about specifically about the vaccination programme. Oh, there we go. Press the right bit of the button, that would be useful. Okay, so this is the sort of graph looking at trends in rolling case rates, and this is for those 7 local authorities in the north of the northeast. And you can see that we're all following a pretty similar trajectory as are most regions in the UK. We're pretty much where we were in the week before Christmas. So looking at the ONS surveillance study, in the week up to the 5th of February, about 1 in 19 people in England had evidence of infection at any one time. So that is an estimate, and it's hovered around 1 in 19, 1 in 20 for that week and the couple of weeks prior to that. The ONS have also done studies looking at levels of antibodies in the population. And in that week up to the 10th of January, they estimated that about 98% of the adult population would have tested positive for antibodies against the virus. So evidence of either vaccination or previous infection, but a lot lower in 8 to 11-year-olds. So between 63 and 72% had detectable antibodies. In Northumberland, it's going down. And it's going down in all age bands. So this is what the picture looks like in Northumberland. I think that was yesterday's dashboard. So case rates do still remain high. We're still seeing over 2,000 cases a week. But when we compare ourselves nationally, those case rates range from 1,432 per 100,000 in Reading to 469 in Oldham, and we're sort of pretty much in the middle. Case rates are still reducing at a sort of reasonably steady rate. We're seeing the highest rates in primary school children, and the reason why we've got high numbers of cases attributed to Druridge Bay ward is because we're still seeing or still managing, actively supporting the management of an outbreak in the prison, which happens to sit in Druridge Bay ward. From a local outbreak management plan point of view, from a testing aspect, we're still actively supporting that through targeted community testing. Obviously, there have been quite a few changes to the testing guidance over the last sort of 5 or 6 weeks, and that has increased demand, but the shortage in testing kits that we saw earlier in the year have largely resolved. There is a move by the Department of Health to rationalise the PCR local testing sites, and hopefully the future of testing will become clearer in the spring plan. Contact tracing is starting to become a bit of a challenge. We don't know what the funding of that will be beyond the end of March. There's also quite a lot of uncertainty about what local authorities' responsibilities will be in the context of contact tracing in the medium term. And as the rules for self-isolation change, actually the public health benefit of contact tracing starts to lessen. But I thought what I really wanted to do in this session today was to sort of focus on the future and where we think we might be going. So we're obviously in quite a different place to where we were 12 months ago. We've got a very extensive vaccination programme, which is supported by a booster. We've got extensive test and trace programmes in place, which include our local tracing partnership. We've got treatments that weren't available 12 months ago, and we've developed bespoke communications both locally and for the region. But we still have very high prevalence of infection, and actually, a significant response was required to the Omicron variant. And of course, we have got this sub-variant of Omicron, which is starting to emerge, which looks as though it's even more transmissible than the current one, but no evidence as yet that it evades immunity or that it produces more severe disease. But what we do know is that if you are unvaccinated, you are 8 times more likely to be hospitalised than you are if you are vaccinated and boosted. We're still seeing a lot of outbreaks across key settings. I think there was one week where we had more than 50 outbreaks in care settings notified to us in that particular week. And we have seen quite large numbers in care homes, but generally the impact on residents has been relatively mild. So a lot of those cases have been asymptomatic, or disease has been very mild. So it certainly hasn't affected care homes in the same way as it had in the past. But what we have seen is a real pressure on staff. So in some of those care homes, over 80% of staff have been off at any one time. Over 40% of staff have been off at any one time. And obviously that puts a real pressure on the care setting in that particular scenario. We've obviously continued with the vaccination programme, and I think we can sort of barely keep up with the guidance in terms of updating the outbreak management plan. But we have got this spring plan, which is expected on the 21st of February, and the Prime Minister suggested yesterday that actually those remaining legislative restrictions, which were always due to run out on the 24th of March, may well be withdrawn several weeks earlier. So we're really waiting to see what comes out of that spring plan. But I think as far as we're concerned, the best defence still remains vaccination. I think the other question is about, whether COVID-19 is endemic. And there are loads of definitions of what endemic is. So it could be when it's highly predictable. It could be when a certain level of harm is accepted because eradication or elimination is too difficult. There are lots of definitions that we could use, but I think ultimately we'll know it when we see it. There's a huge amount of uncertainty about long-term patterns, but a reasonable degree of confidence that we need to expect future waves of infection, and those will be determined by 4 things. The first one is new variants. They are really unpredictable, and when we get them, we could see variations in transmissibility, variations in severity of disease, and variations in immune escape. It will also be affected by the changes in the number and the age distribution of susceptible individuals, and that will be influenced by vaccination policy, by waning of immunity, and by births and deaths. It will be influenced by seasonality, and it will be influenced by the extent of social mixing. And whatever pattern we see in the UK will be temporary until we get until global disease distribution has settled. So they think in the longer term, seasonality will be important, but in the shorter term, the patterns of disease will be driven by waning immunity and new variants. So in terms of is COVID-19 endemic, we are definitely not there yet. So in terms of sort of current priorities across the LA7, we've been working really closely as a group of local authorities and directors of public health to look at what our priorities are and will be, and clearly a lot of that is focused on equitable deployment of both the COVID and the flu vaccination programme. And we have sort of reinvigorated our vaccine equity group to make sure that we are making that programme, the booster programme in particular, as equitable as we can. We certainly need to normalise those basic infection prevention and control behaviours, so hand washing, respiratory hygiene, good ventilation, face coverings. The more we can normalise that, the more we can the better we can manage transmission. As I said, we need to update our local plans to reflect the spring plan, and we need to make sure that we can respond to future waves of infections. So we need to think about how we can surge testing in response to waves and outbreaks. I think taking our communities with us is really important, and I think the local, sub-regional and regional communications that we've done, which is very much based on behavioural insight work, has been really effective. We need to continue to focus on vulnerable individuals in the community, and I think there are loads of people in our communities who are still very reluctant to participate in society as they used to because of a fear of infection. Continued monitoring, surveillance. We need to be able to identify those new variants when they emerge, and we need to refocus our work on health inequalities. So things that we need to consider, which hopefully will come out of the spring plan, is, what is test and trace going to look like once the need to self-isolate is removed. So we're anticipating that NHS test and trace will be scaled back. Will we need to test, and what will high-risk settings require? So we need a testing regime which is proportionate, and as I said, which we can stand back up quickly. We need to think about what will happen to NHS test and trace at the end of March. And as I said, what will the local authority health protection functions be, or what is the expectation of local authorities? How can we effectively promote those IPC measures that I've talked about? They need to become business as usual for us. There is a national programme looking at wastewater testing. So we do get regular reports looking at levels of coronavirus in wastewater, and that can give us early signals of virus in our community. So we need to think about how we can use that more effectively. Being prepared to stand up interventions again, so vaccination, testing, support for self-isolation. And then we need to really pivot our focus back to existing health inequalities and those that have been made worse and exacerbated by COVID-19. So really, the next steps for us are around developing a framework for living safely with COVID-19. So regionally, we've got a workshop next week with our directors of adult social care, directors of children's services, with UXA, with the Office for Health Disparities and the NHS, to look at what that's going to look like. There's work nationally with the Association of Directors of Public Health to develop a strategic framework for living safely with COVID. We need to review our priorities and identify where we can work together at scale. We've done that really effectively in the past, particularly in relation to comms and the vaccination programme. And we want to develop a shared programme of work across the LA7 to really focus on health inequalities, potentially looking at the really effective regional programmes that we've got for alcohol and tobacco, to look at whether we can take a similar approach to other areas. But I think in terms of the sort of messages that we need to give out, the first one is that case rates are falling, and that's really good news, but they still remain very high, particularly in school-aged children. We are going to expect, or we need to anticipate further waves going forward, and I think it will take a couple of years before we settle into, any sort of reliable pattern. And actually, the subgroup, the specialist subgroup which sits under SAGE, was saying that it could be a decade before globally we get into any sort of steady state, and of course that will affect what happens to us in the UK. Vaccination very much remains the linchpin of everything that we do, and I know Rachel will talk about the vaccination programme and what we may or may not see in the system letter, which we're anticipating. And as I've said, continuing with those basic measures is really important. They really have very little impact on our daily lives, but added together, if we all do those really simple measures, they have a massive impact at population level. So we need to think about how we just embed those into everything that we do. So I think that's it from me. Very happy to accept, or very happy to answer any questions if anybody has any.
Any questions at all? I think you might go off scot-free. Do you want to talk about the vaccination rollout then?
Yes, happy to. Thank you very much. I think the slide's just been loaded up. Great, thanks very much, Leslie. So, vaccination programme. So I'll just run through the performance to start with. Oops, there we go. So here we are. So we still are performing really strongly with our vaccination programme, although we have just been knocked off the top spot for our first doses in England to now the second, but it is only Rutland and they're very small, so I think we'll probably pick that back up again. But we are still highest for our second doses and 7th for the booster programme, so that's 90% have had their first dose, 85.6 second doses, and we're at 71.1% for our third doses, and we are still significantly higher than the England national average, so we're still doing very well. This graph just shows the sort of 3 mountains I think that we've climbed in each of the waves of the booster, and every time we've done a rollout of the vaccine, there's been less people obviously come forward, and certainly that is true for the booster programme, and it has been a much slower uptake of that booster, and that's something we need to think about for going forward. This also just shows our performance, but it's just now broken down into particular age groups, which is, there's still lots to learn from the different age groups and how they respond and how we provide a service to them going forward. But we have vaccinated now 86% of the eligible population have had that booster, but you can see that we still need to focus on the under 50s because they've certainly been slower at coming forward. There are various reasons for that, which I'll just come on to. So the Get Boosted Now campaign started during December, and we did see an increase in the booster delivery at that time. But as we headed into the new year, then it absolutely did slow down. And this was very much coinciding with the Omicron variant. And obviously then we had large numbers of that population who had COVID, and they had to then observe a 28-day post-infection period before they could come forward for that booster, which was quite a challenge as we had laid on lots of clinics, but we had lots of cancellations to manage. There is a very specific comms and engagement campaign targeting the under 30s, which is called A Change of Heart, just trying to increase the uptake in those cohorts. And we don't necessarily totally understand why they're not coming forward, other than people may think they've had 2 doses of the vaccine and don't need that third, and so they're a bit slower at coming forward. So we're trying to just increase the comms and engagement around that. We have also done quite a lot of targeted work amongst pregnant ladies, and we've linked in with maternity services and often had midwives available at clinics for people to talk to, and that has been very well received for that group. The fourth doses, so I suppose the second boosters for the severely immunosuppressed, is currently being rolled out at the moment. And then our 16 to 17-year-olds that are at risk and our 12 to 15-year-olds who are now eligible for a booster are also starting to be invited for that booster. So the main group that we're really looking at the minute is children, really. So we know that the first doses of COVID for the healthy 12 to 15-year-olds started in schools in late September and ran through to November. So we are in the top 10 for our first dose uptake for the 12 to 15 and the 16 to 17-year-olds. We are now inviting the 12 to 17-year-olds back for their second doses. And boosters as they become eligible, and we're using local and national booking for that group. And then the second doses for the 12 to 15-year-olds is also being rolled out, and again we're using a wide variety of options, including national booking, pharmacies and primary care. We're also now just starting with the at-risk 5 to 11-year-olds, and the PCNs are inviting them in as they're doing their checks and inviting them in at the moment, and we'll be getting a third of a standard Pfizer dose for that particular group. And again, uptake on this is quite slow, and primary care are working really hard to contact families and talk to parents, as well as wearing really child-friendly scrubs in their clinics to make it a more friendly appearance for this young group of children. And we are still awaiting guidance with regard to a wider rollout of the vaccine for 5 to 11 or the healthy cohort. And we don't equally know whether the 12 to 15-year-olds will require a booster. So just waiting for JCVI excuse me, to let us know about that. So we are continuing, as ever, to offer an evergreen offer, and as Liz says, the vaccination programme is still very, very important. So, the offer for vaccination is absolutely open to all in primary care and vaccination centres and pharmacies. But we are obviously looking at that data and being really clear who hasn't had the vaccines, and you can see there the breakdown from the particular age groups. We do have the Northumberland Vaccine Equity Board, so there is a lot going on there looking at inequity and particular groups that might require a more targeted intervention going forward. And because the programme has absolutely slowed down, that does give us more time to really look at that and make sure that we have offered and are working really hard to make that convenient, build confidence and try and avoid that complacency. So as Liz said, we're also really keen to work out what the next steps are for our vaccination programme and how can we move out of a sort of an emergency sort of led programme to more of a business as usual. We are assuming, but it is an assumption until we get our system letter, that we will be providing an annual COVID booster. And we think that will be to the sort of over 50s, so those in the JCVI cohorts 1 to 9, so that includes the sort of clinically vulnerable group. And we assume as well that might then be delivered in winter, along with the sort of flu campaign within the sort of autumn, winter time. And that would obviously make it much easier to administer, because there's a campaign going on at that time. The actual supply chains are unlikely to be aligned, and that's just a challenge just because the COVID vaccine is a nationally run campaign, and flu is ordered individually by pharmacies and primary care. But we will be looking to, plan this. How are we going to do it? When are we going to do it? And look at how do we roll it out in a normal time frame. And I think probably it would be also helpful to know how to roll that out at surge, if and when we have more variants, or if told to do it at pace. I think a significant challenge is maintaining the importance of the vaccines, and the workforce that we have employed are all very much on temporary contracts, which will sort of come to an end. end, and we'll kind of lose a lot of our volunteers. So it will be quite a challenge if we kind of slow the programme down and then start it up again in the winter, to make sure we've got the right workforce in place in order to continue to vaccinate, as well as deliver all the routine health and care services, and tackle ultimately, you know, the backlog in elective care, which is a big focus as well at the moment. So still lots unknown, and hopefully the system letter will give us a bit of clarity on all of that. Thank you very much. Happy to take any questions.
Okay, we've got any questions on the vaccine rollout? Yes.
Thank you very much, Rachel. It's just you didn't you alluded to the future arrangements, and we all accept there's been absolutely magnificent effort across Northumberland, and we've all done very well. We won't go into the fallout from that, but there have been various suggestions that the vaccines will be taken out of normal settings, i.e. primary care and, you know, trusts, etc., to a more centralised. Now, it feels that would be something which should be considered within, you know, a setting such as ours, maybe sort of alongside other delivery. Have you had any thoughts about that? Because I think this is, you know, as you say, people think, oh, next winter's a long way ahead, but actually the planning for next winter's already started as far as the flu campaign is concerned. We're in the dark as far as COVID, obviously, but it's just these more logistical things. What are your thoughts about that going forward?
Yeah, thanks, Jane. It is really difficult, and I suppose in Northumberland having a central vaccination site is quite a challenge in our rurality, which is why I think our success has been with the spread with community pharmacies and vaccination sites, as well as primary care. So we've kind of tested loads of models so that they're all there ready to use as and when we know what we're doing. And I think hopefully we'll get the system letter, which is imminently due, and then we'll have a better idea of what we're going to do going forward. I think we would really like to see flu and COVID delivered together if it is going to be done in a winter. And I know primary care are always keen to look after their most vulnerable clients, and they vaccinate them against flu. So I think we've got the plans. We just need to be told what we're doing, really. I think we could do a number of different things. We've got a lot of expertise now. It's just we just need to be told what's happening and what's going on, I think.
But I think it was just to make this board aware that we have got very good relationships between community pharmacy, primary
Absolutely.
care, the CCG,
Yeah.
and the trust, so that we have a good infrastructure, and rather than we've tested out an awful lot of stuff so that actually we could be innovative and
Absolutely.
have a really good vaccine delivery programme.
Yeah, definitely. Oh, yeah, very confident about that. Yeah, thank you.
Okay, have we got any more questions? No, thank you very much. There's very detailed reports. That's probably why I haven't had many questions. So thank you very much for that report, and we'll see what happens. Okay, I go to the next item on the agenda, which is item 5, pharmaceutical needs assessment, to update the Health and Wellbeing Board of progress and plans for refreshing the statutory Northumberland pharmaceutical needs assessment (Pna) and agree the lower geographical level for assessment. And I think, Liz, this is your report, isn't it?
It is, thank you very much. So one of the statutory duties of the Health and Wellbeing Board is to assess the need for pharmaceutical services in its area and to publish that assessment, and that is effectively what the Pna is. There are some very specific regulations which define the minimum information that needs to be included, the publication timescales, the minimum consultation process, and a couple of other specific matters that the board has to consider. So our last Pna, which I think was the second one that we'd done since the Health and Social Care Act was introduced in 2013, was back in 2017. They're due to be refreshed every 3 years. So what we should have had in place was a refresh in 2020. But because of COVID, that timeline was delayed, and now the expectation is that local authorities will have a refreshed, or health and wellbeing boards will have a refreshed Pna in place by sort of September, October of this year. The Pna is really a key document because it's used by NHS England, NHS Improvement, to determine whether applications to open new pharmacies are approved or not. And since the last Pna, there's been a whole raft of guidance documents which have come out, I think the intention of which is really to ensure that Pnas across local authority areas and between local authority areas are much more consistent and comprehensive, because if we don't get it right, there is a risk that we will be subject to judicial review if a community pharmacy application is turned down on the basis of a Pna which isn't up to scratch. One of the things that we are required to do is to look at pharmaceutical needs on a sort of sensible geographical level. And the reason for that, the selection of that sort of sub-county analysis has to actually appear in the Pna. We've got a Pna Steering Group which has been up and running since August of last year. That includes the local pharmaceutical committee, the CCG, the trust and a whole range of other representatives from interested parties. And the conclusion that they've come to is that the best bet for us is to actually stick with the original CCG locality areas that we've used in the previous two Pna documents. The big advantage of that is that we can then compare those needs with previous years. In terms of timelines, we're intending to bring a draft to the Health and Wellbeing Board in April, and assuming that the board is content with that, we will then go out to formal consultation with a view that a final draft will be brought back for approval in September. So the two asks of the board today are really to support the sort of plan and the proposed timeline for the Pna, and to approve the use of those previous CCG localities as the geographical basis of the 2022 pharmaceutical needs assessment.
Okay, thank you very much for that. I will come to the recommendations in a moment, but first I'm going to ask if anyone's got any questions or comments on that. Yes.
Sorry, me again. On behalf of the Local Medical Committee, to thank Liz and her team and to Anne Everden for working with us so closely, because although on the face of it, this seems a very technical document, it has great implications for Northumberland in terms of our rurality, distribution of services, and also the move to self-care and to lots more services moving into community pharmacies. So also thank you to the Local Pharmaceutical Committee for working with us. And this also involves, because for members of the committee who may not be aware, it also involves a lot of work around although it doesn't directly involve dispensing doctors, it does involve the service assessment of the coverage of their services. So really just to say thank you for giving the update and for the very meticulous way in which it is being developed. And I think just to stress how important this is going to be, and actually it's not set in stone, because these services and the way that the services are delivered, Chair, are changing constantly.
On reflection, I should declare a conflict of interest because I'm in a practice which is a dispensing practice. So I'd like just that to be made noted. I also think one comment on this is to back up the point made earlier about rurality. This doesn't necessarily consider late opening and bank holiday opening, but certainly for people who are living further north in the patch and in the west, at times gone 6 o'clock, there's great distances need to be travelled by people to access some of the later opening pharmacies. So if that could be considered in this as well.
Okay. Thank you. Any other comments or questions? Can't see any, so I'm going to move to the recommendations. We've got the two recommendations there which have been laid out by Liz. Do we support those recommendations? Yes, I can see. Yes, we do. So that's great. Thank you very much for that committee, or board, should I say. And what I will do, we'll wait for that to come forward down the stream as well. So we'll come to the next item on the agenda, which is, go back to my front sheet, it is item 6, safeguarding adult annual reports and strategy refresh to receive an overview of the work carried out under the multi-agency arrangements for safeguarding adults in 2020-21. And it says a report from Karen Wright, Senior Manager, Safeguarding Adults. And I've got Paula Mead on the front there. So,
Yeah.
over to you.
Thank you, Chair. Karen Wright couldn't come this morning, so she wrote the report, but I'll be presenting it, if that's okay.
Great, thank you.
Chair, can I just ask if you would mind if I sort of bundle up this item and also the next one, which is the children's annual report?
That's absolutely
because
fine.
there are some commonalities which I can just sort of say.
Thank you very
once.
much, yes.
Yeah, thank you. So to start with the adult safeguarding arrangement, the report, but also the children's, I suppose, we have a statutory duty with both to produce an annual report which looks back over the previous year and just, I suppose, dives into whether our achievements, how we're managing our priorities, how we're progressing with our priorities, and setting out what it is that we need to do going forward, and also identifying any serious case reviews that have emerged during that year. So in terms of the adult board, just to note that it is actually a combined board, North Tyneside and Northumberland, and so the report reflects that, and I'll just be speaking to the Northumberland aspect of that, and I'll say more about what the plans are for that going forward towards the end. It won't be a surprise, I think, to the board to hear that the pandemic has had quite a significant impact, and the management of the pandemic, particularly in terms of lockdown, has had a significant impact on the arrangements that for all agencies with a duty to safeguard. You know, adults, talking about adults at the moment, so adults at risk, and we've had to actually really sort of change our ways of working. Everything has been risk assessed quite rigorously, and the partners have given assurances through the means of a risk register to the board in terms of how they're managing these risks and the mitigations that they've put in place to manage those risks. So overall, it's been a challenging time for both the adults and the children's board. However, both of the reports, I think, identify that things have been managed reasonably well, pretty well, and that everybody has really used very sort of innovative and creative approaches to reach out. Risks have been assessed, and as I say, face-to-face has been maintained where it can be, and virtual management has happened. So, for example, training of staff, that's become very much a virtual arrangement, and that's worked reasonably well. And in fact, there's been some lessons we've learnt through that, which have been quite helpful, really, and we may use some of those lessons going forward. So as I say, we convened a multi-agency risk register. In the early stages of the lockdowns, we were meeting fortnightly as a partnership, and we combined the children and adults meetings because we realised and recognised that they were actually risks that could be dealt with together, and that some of the management of those wouldn't be very different. So during that period, Northumberland experienced a 40% increase in adult concern notifications and a 14% rise in safeguarding inquiries. A lot of those were related to people in their own homes, because clearly care homes at that time were locked down, and that I can say some more about that in a minute, because that isn't something that we took our eye off. The rises of domestic abuse, again, that was something that really did increase during this period, and that impacted on both adults and children. Most of our referrals were from the police. So that's in line very much so with a national picture. It's not just in Northumberland or in the North East. That's something that was very much a national concern. On a more general note, the impact of the COVID restrictions have been evident in safeguarding concerns, and they relate very much to isolation, mental health and well-being, again, both for adults and children, really. Our local arrangements, our operational arrangements through the multi-agency safeguarding hubs, or MASHs, they're operating really well and have been operating well, and we're quite slightly unique in Northumberland in that it's an integrated adults and children's MASH, and that's quite different in most areas. And actually that's been a very positive arrangement, and it's been noted nationally as a positive arrangement. And it's enabled us to really tackle some of the very difficult transitional issues of vulnerable children moving into adult services, and it helps with a more holistic approach. There haven't been any adult safeguarding reviews in Northumberland during this year. There was one in North Tyneside. There are a couple of joint reviews which have been published for a young person, two young people actually, and that learning's been sort of identified in the annual report. There's a lot of there's been quite a bit of work that's gone on around transitional safeguarding, because that's been an area that we needed to work on, and also safeguarding dependent vulnerable drinkers project, which has been very much welcomed, and again something within COVID that maybe has been highlighted as an issue. The report sets out our key strategic priorities in both the adults and children's, and talking about the adults at the moment, clearly COVID has been an overarching priority, and it's impacted on all of our work and all of our priorities. And so, as I said earlier, responding to risks and early identification of those risks has been key. The second priority, transitional safeguarding, there's been quite a lot of work done around children, as I say, vulnerable children moving into the adult arena, and protocols have been developed and put in place for vulnerable young people. Domestic abuse, because that is such a key area and has been a key area over this last year or so, that's been a real focus for us in terms of early identification and prevention, working with partners, the police, health, social care. It's been very much a focus for us. Criminal exploitation has been another focus for the Adult Safeguarding Board, and we continue to focus on making safeguarding personal, so that people who have care needs and who are vulnerable are involved and very much empowered to make decisions within that system. In terms of the plans going forward, we had an independent review of the Adult Safeguarding Board over the last year, and it identified that the joint board, Northumberland and North Tyneside, was valued and, you know, was working quite well. However, all of the partners felt, and I think that's been particularly exacerbated by COVID, that we really need to focus more on place, and so it's been agreed through a process of consultation with our partners to separate the two boards. So from April this year, the two boards will be separated, and North Tyneside will make their own arrangements, and Northumberland will make their own arrangements. And one of the things that we are very keen to do, and which there's been some, as I say, learning from the way we've managed COVID, is to join up and integrate the children and the adults board much more robustly, which we couldn't do when we were working as part of a North Tyneside approach. We'll still be working with North Tyneside and our other regional partners, because there is regional work that is important, and which we can still continue to learn and support each other through. I think that's probably all I want to say specifically about the adults report. In terms of the children's, it's slightly different. The arrangements are slightly different in that a couple of years ago, the local safeguarding boards were disbanded, and new arrangements are put in place, and they are arrangements whereby the local authority, the CCG and the police become the statutory safeguarding partners. The board, so there isn't a board in that sense. Each of these three partners have equal responsibility to their duties to safeguard children, and they are the lead, if you like, for safeguarding of children. And this, as I say, this replaces the local safeguarding children's board. That doesn't mean to say that other partners, for example, the health, the schools and voluntary sector organisations are not absolutely involved in and still have duties to safeguard the children. This is just around leading, if you like. So one of the, I think, very positives in Northumberland is our partnership working, and with both the adults and the children's board, that partnership working really has come into its own over this period and shown itself to be quite effective. What we need to do now is there's still some work to be done around really sort of solidifying those new arrangements, but they are working well. We've done quite a bit of development and work with the partners, and we concluded, as I said earlier, that we need to move more closely to the children's to work with the adults and children's arrangements together. So the report is, there's very specific things required in the children's annual report. And that includes, we have to include evidence of impact and an analysis of our progress against our stated priorities. We have to include any decisions and information around safeguarding, local and national and safeguarding practice reviews, as were called serious case reviews. They have a new name now, but they're basically very similar things. We have to include information about how we've sought feedback from children and young people and built that into our planning. And if we have a secure unit in our area, which we do, we have to include a review of restraint of those placements. So those are requirements in our annual report for children. And they are all included in the report. So in terms of priorities, it was a bit of a sort of year whereby we reviewed our priorities, and the priorities that we had been focusing on, they're still important things, but they now have become, if you like, embedded in business as usual. So that included a focus on prevention and early help. That included working with fathers, and also I'll look at improving the focus on the child's experience, and also criminal and sexual exploitation. All of those things continue to be absolutely key and important, but they now are sufficiently embedded for us to have a look at maybe some other priorities which we needed to include. Clearly, the overarching priority of COVID and the impact on COVID, which, as I said earlier, impacts on all of our priorities. Children and young people's mental health, which has again always been a priority, but now it's got a much more focused look at this. Neglect has been a priority for some time because neglect is a stubborn issue in Northumberland, and continues to be the area where children who have child protection plans, neglect is stated as the issue. Early help, as I said, that now is really sort of under really embedded, and we're doing quite well with that, and there's quite a bit of evidence to suggest that progress has been made with that. Our focus has also been on domestic violence, and also child-to-parent violence and abuse as included it within that. And the other area of priority is non-accidental injury to the under ones, because we know that an under one is 8 times more likely to suffer serious harm than older children. So those are the priorities that we've been working on, and overall, my role isn't just as chair with the children's work, it is as an independent scrutineer. And overall, my conclusion when I've looked at the data and the evidence and some of the soft data as well, is that we're making good progress, that partnership working continues to be effective in Northumberland, and our assurance, our processes and our assurance frameworks are working as well as they can do. Thank you.
Okay, thank you for that. Is there any questions or comments on that? Yes.
Thank you, Chair. As one of the lead statutory partners for children, I really welcome the developments that we're looking at, both in terms of adult and children. So we've done a lot of deep thinking and development sessions around this, and are just working on that now. And we learn all the time, and there are pros and cons to all of the options. But I do think we're getting to a really good place on this. Certainly from a children's perspective, having the 3 lead partners has been a really good development, but I do want to take others with us more. It's centrally in that journey as we go forward. I definitely think we're very keen to look at how we keep independence and scrutiny in the process going forward. And I do want to say thank you to Paula for all of her work as both chair and independent scrutineer. So we're taking a really good look at that and learning nationally. And just one of the things to say is that quite a lot of the practice from our area has been picked up nationally as good practice, and I just want to say that because we are always trying to push the boundaries in terms of innovation and doing the best thing for vulnerable people, whether they're adult or child. So really looking forward and committed to all of this work.
Can I just sort of say something? Thanks very much, Siobhan. I think particularly the SIRS work that you're making reference to, and that's the sharing information regarding safeguarding between GPs and midwifery and health services. That's been something actually that's been noted nationally as an area of very good practice, and has actually helped us to identify where parents perhaps need support, more needs, or maybe where there's risk that we hadn't recognised earlier. So thank you for that. And also absolutely agree with Siobhan around making sure that we carry forward our relevant partners, as they're called now, which are the other partners beyond those 3, because they actually are fundamental to the whole safeguarding system, and we absolutely intend to do that. So,
Got Councillor Wendy Patterson.
Thank you, Chair. Paula, I really just want to say thank you, and to include actually Siobhan, Graham, everyone who takes part in the safeguarding meetings, because I've attended quite a few, and I think we're really, really lucky to have such dedicated people looking after our children and adults. So thank you very much indeed.
Thank you for that. Yes.
Thank you. Two questions, if I may, but first of all, just thanks to Paula for some very, very detailed reports, which are generally positive, which is very assuring. But in the context of linking the children and the adult one together, I notice in the children one, there's a significant amount of scrutiny and lessons learned. There's the dashboard, pages 96 to 97. There is, what you are doing and have done, 10 pages on that, and an independent scrutineer's conclusion. There seems to be less of that sort of scrutiny lessons to be learned in the adult one. Is there a reason for what appears to be a significant difference there, or not?
I'll look this way.
Yes, okay,
Talk to the microphone. I suppose they were written by 2 different people. I wrote the children's report, and the business manager wrote the adults report. But I think more so than that, probably in relation to the children's report, there had been a national research look at the year before all the annual reports, all the children's annual reports. And it was that piece of research which did deep dives and came up with recommendations for what needs to be in the children's report. So I read that quite carefully and tried to include all of that in the children's report and use that as a framework. So that's part of it. I think, though, the other part probably is, if I'm honest, I think the the evidence base and the data that we collect for the children's work is actually more robust and more detailed than it is within the adults within the adults safeguarding arrangements. And there's a number of reasons for that, and some of it is history and the way that the two boards or the two sets of arrangements have evolved, and some of it is the quality, I think, particularly in the Northumberland. Alan Hartwell, who leads the performance team in Northumberland, is absolutely second to none, and it's very easy to get data through that subgroup which works to Alan, and it's a multi-agency subgroup, so it's multi-agency data. It's been a bit more challenging to get the adult data, if I'm honest. And some of the problems has been that we've been comparing Northumberland and North Tyneside adult data also, because it's been a shared. But actually, when we have done that, we've found that it doesn't work very well because it's collected in different ways in the different local authorities. So some of it is about that quality and that history of data, and some of it's about the way the reports have been written, I think.
Okay, thank you. There just seemed to be a significant difference in that area
style,
in two
perhaps.
reports.
I think Graham wants to add something, actually. Perhaps.
Thank you. I'm Graham Wright, Service Director for Children's Social Care. And I think the other element they've been working on is, as well as the performance data, looking at the qualitative impact, looking at the range of ways in which we understand the quality of practice arising from the performance data. And I think the opportunities for us in terms of integrating the two partnerships, that we can take the learning that we've developed in children's about how we understand the impact of the work and help support and develop that alongside the adults as we combine the two boards going forward.
Okay, thank you. And the second one, in the context of commonality between the children and the adults, there's one theme which seems to stand out. For example, for the adult one on page 54, it mentions that more could be, this is the reviewer, more could be done to hear the voices of people who use the services and frontline staff to ensure these shape the developments and direction of services. And similarly on page 105 for the children one, this is the independent scrutineer, comments further work is needed to monitor transition outcomes based on feedback from the young people themselves. And however, the partnership needs to understand and apply children and young people lived experiences at a strategic level. So there's a significant commonality between the two reports about listening to the experiences of young people and adults in helping to shape your services. So will that continue to be a significant priority in what you do in the future?
Yeah, you're absolutely right, David. That is absolutely. It's actually one of the most challenging parts, I think, about trying to sort of get that built into both of those arrangements. And I think individual agencies work very hard to do that. So, for example, in adult services, the Making Safeguarding Personal work, that is all about listening to and integrating their experiences and their wishes and their, everything into their plans. And but that's on an individual level. So I think on an individual level, in both cases, practitioners and professionals have worked quite hard to do that. It's actually trying to address it from a more strategic approach, I think, is probably the challenge. And so that it's not tokenistic and that it's real. And it's just something that we need to continue to be working on and doing, to be quite honest. You're right to point it out. It's something that we need to just keep our foot on the pedal with. Okay. And I think Graham wants to add something.
And if we just take that example again about the opportunities for the integration between the two partnerships. In children's social work, child protection is based on risk within the family. And the bottom line is, if the legal evidence is there, we can remove younger children. Now, as young people move into adolescence and then move into adults, actually that approach is not effective. We've got to find very different ways of working with and making safeguarding personal for adolescents as well. So the principles behind which we work in children's services, moving into the transition, supporting the work to adults, is making sure that we're aligning that more effectively to make sure our safeguarding can support children from their adolescence into adulthood more effectively with person-centred approaches, listening to the experiences of that person. Because, I mean, just realistically, in adolescence, forcing them to do anything is not an effective way of working. We've got to work with them, and that does bring risks and challenges. But I think the work that adult services have done in making personal, there's learning back for children as we develop that between the two services and the partnerships. I think it's a really effective opportunity for us.
Okay, thank you.
Thank you for the report. I think it builds on what Graham was just saying in my mind, in that I think culturally there is something a little bit different between child safeguarding and adult safeguarding and our approaches to it. And I think this comes down to that idea about perhaps capacity. And I think there's some education to be done around the assertiveness and the use of the Mental Health Act, especially around people with complex problems and alcohol use. And I think there's a lot to be learned and built on, and combining the two to make them on an equal footing would be really useful. Thank you.
Thank you. If I could just respond to that. I think that's a really good example, actually, and the work that we've done with alcohol-dependent drinkers. It's this thing about capacity and adults. It's more complicated in many ways, adult safeguarding, than children's safeguarding from that perspective. And the work with dependent alcohol drinkers of alcohol who are dependent and resistant, the work that we've done over the last year with that project has been really helpful, because it's enabled us to train practitioners who maybe previously would have said, well, actually, that adult is making their own decisions about this and they have capacity. And actually, the training that professionals have received as to what statutory tools they can use to actually manage that and overcome that has been really helpful, because that may not be the case. People may appear to be making decisions, but who would make a rational decision to be harmed? So you know, I think that's a very good example, so thank you.
Okay, any more questions or comments? I can't see them, so we just note those reports, and thank you very much for the presentation, very detailed, and as I say, thank you very much for that. Okay, I'll go on to item 8, which is the forward plan, just to note and discuss forthcoming agendas at future meetings. The latest version is enclosed. Our next meet, I've got no urgent business, and I've got the date of the next meeting of Thursday the 10th of March at County Hall. Yes, David.
Could I just pass a comment on the reports which have been read and presented this morning? And if you look at the pandemic and the vaccinations and the precautions and the very comprehensive reports on children and adults, I think the conclusion really needs to be that as a county, you know, we remain in very good hands.
Absolutely. I couldn't second that strongly enough. Very much so. Yes. Thank you. That's great.
Just on the forward plan, I would like to highlight the importance of the Health Inequalities Summit and make sure that we put time on our agenda to take that forward.
I mean, we've had difficulties in scheduling that with COVID and such like, and if those COVID pressures are easing somewhat, then I'm sure we can progress that now, because I know we're very keen to. I know the leader is as well. I'll go to Wendy, then I'll go to the leader. Wendy?
I just wondered if we could have another update on ICS and where this is for the next meeting in March. I think we just need to have regular updates on where this is.
I'd be quite happy for that to be on the next agenda, very much. Thanks. So if we can. I've got a plethora. Does the leader want to come in now?
Just on the Inequalities Summit, we have a date of the 25th of March for that, and invitations will be going out fairly soon. I do hope as many can come as possible, because it is a very important part of our budget going forward and our work plan. You know, it's an acknowledgement of all the really good work that goes on at the moment, but really to see what more we as an administration can do to help join everyone together and have more input to help progress the reduction of inequalities.
Absolutely. Yep. I've got David and I've got Paula. So David.
Thank you. Just I'd like to support the need to look at the integrated care system and particularly how the System Transformation Board and the Overview and Scrutiny Board and this particular committee, how they can develop their remits and work together within place in the context of the ICS.
Yeah.
I think time, I know that the implementation has been delayed until July, but I think it's urgent that steps are taken to integrate how those three groups, those three committees work and work between themselves and with the ICS.
Yep, totally agree. Paula.
Could we add the Child Death Overview Panel annual report to the forward agenda, please? Previously, that panel, which is a North and South of Tyne panel, which looks at child deaths and some of the reasons behind those and comes up with analysis, that was the governance of that was through the local Safeguarding Children's Board. The governance now is through health and wellbeing boards, and it's been delayed because of COVID basically, and it's now available. So although we have scrutinised it through the Children's Partnership, it actually does now need to come to this board.
Yep.
That's okay.
Right, that's if that can be added to the forward plan, that'd be useful. Thank you. Any more comments before I close the meeting? No, so I think that the main thing is the ICS thing to get onto agenda if we can, hopefully for the next meeting. I've got no urgent business, so the date of the next meeting is the 10th of March, and it's here. Whether it's in the chamber or whether it's here, I don't know, or in another room, I don't know. That we might have made progress on that, I don't know, but it'll be at County Hall somewhere, so we'll go for that. Okay, thank you very much now. Thank you.